about 110. Did you want one of these?
I've got my tea. Thank you.
Okay. I do have, if you're interested, LaCroix. That is mojito flavor.
You know, I don't love sparkling water.
Oh, really?
Yeah. I don't know. There's something about the sparkle.
It's one of my favorite things.
I've had, there's some brands that I'm okay with, but I don't know. I just prefer flavor, if I'm going to do flavored water, it's just like regular flavored water. Like I'd rather drink
sugar water.
No.
Like, what do you mean regular flavored water?
Well, there are brands that aren't sparkling, but have like Hint is the one I'm thinking of. Although I stopped drinking them because I try to avoid stuff in just plastic bottles. Mm-hmm. But it's, it's not sparkling, and it's like I don't know. They have like an apple, like.
I think there are very few of those.
There are a lot more sparkling water brands.
You know what there are a lot more of? And it actually kind of pisses me off. Sugared drinks.
Yeah.
And highly caffeinated drinks.
Yes.
Yes. I go to Quick Trip looking for one of these. Yeah. And a lot of places don't even have one.
Yeah. No, you've got the sodas, and then you've got your energy drinks. Those are your options. Yep. Yeah.
Yep. And wall to wall.
Yeah.
Of them.
Yeah.
It's like, okay, how much of the same thing can you freaking sell?
And and it's so interesting. I mean, I work with a lot of teenagers, right? And certainly not all teenagers. Like, I never want to paint everybody with a broad brush, but the number of teenagers out there who live on energy drinks, I'm not saying anything new or different there, but it's shocking. And adults too, and 200 milligrams, it's, containing drink of caffeine. And that's so, like, a standard cup of coffee, which is what, like, when I was a kid, that was the caffeinated beverage people drink.
Well, it's like 100 grams of caffeine, right?
At most, like 65 to 100, depending on what kind of coffee it is. Even like your standard Coke, can of Coke has like 35 milligrams of caffeine in it.
Is that it?
Yeah.
And the same amount of carbs and sugar.
Right. But, a Diet Coke or whatever, if you're going to go the sugar-free route.
What about Mountain Dew? I know that was like
Mountain Dew is higher, but it's still
a cup of coffee. High.
Yeah, it might be closer to 100 depending on how much you're drinking, but it's certainly not your Celsius or Monsters or Red Bulls or those sorts of things. Yeah. So, and it screws up people's sleep so much, right? Like, so ideally you should avoid any caffeine within like 10 hours of when you're going to go to sleep.
10 hours?
10 hours. And people may say, I can drink a Red Bull and fall asleep. And that may be true, but it's affecting your sleep. It's affecting your sleep patterns. Maybe you're not getting as much deep sleep. Maybe you're, I think sleep is a very interesting area that I don't know enough about, but want to learn more about because
that's why I was going to stop you for just a second, because you're talking like you're some sort of authority on this.
Well, I know a little bit about it because I've had trouble with my sleep, but
Let's also take a step back and let's talk about who are you? So this is do we go by Antoinette when you're working, or you go by Toni?
I go by Toni.
Toni, Dr. Toni Peters.
Yes, Dr. Toni Peters.
Has been working at the Gundersen Health Clinic for
just over 18 years now.
Okay.
Yeah.
Okay.
Yeah.
You're giving away a bit of your age by saying that.
Well, I am proudly 50 years old.
Proudly just turned the big 50.
I don't care to hide it. I don't understand the purpose of life.
Yeah.
Because of what I do for a living, I see aging as a privilege. So not everybody makes it to 50, know?
That reminds me of a story that, because I sell pictures, right?
Yeah.
Farmers. So there was a guy who used to have an airplane, like an open body airplane, and he would fly around. He'd make these little packages of candy.
Oh.
And he'd weigh them out. I know this because I've tried to sell pictures to him before, and I've seen the scale and the baggies. He'd weigh them out, put a specific amount of candy in every little bag.
Yeah.
And he'd take him up in his airplane with him, and he'd drop him from his airplane, and all the kids would come running. You see the airplane; it's a yellow airplane.
Yeah, I mean, if you knew who he was and who was coming, like that'd be great. If I randomly saw a little like plane in my neighborhood and
it's like the ice cream truck, right?
Dropping things, I'd be like, "What's going on?"
Totally.
It might make me a little nervous.
So he used to. People obviously knew him all over town.
Sure.
People told me, like, don't ever ask him his age.
Yeah.
And apparently he was, 91 years old and still flying airplanes.
Yeah.
Right?
Yeah.
And he didn't tell anybody his age. He'd get upset when you asked his age.
Yeah.
And then this last time, I think it was not even a year ago, I went and had a picture of his place. It's got a amazing, like, it's the Scandinavian, what's that? Norskadalen thing. It's kind of in that area. So really, really Scandinavian area. Right. Anyhow, his home's like these perfectly designed little houses, like multiple little houses back in the middle of the woods. It's really, really sweet, and it's designed really beautifully and everything. Anyhow, so we take pictures, and I was there, and he invited me in. He's always inviting you in while he's eating. He's always eating something. And I kind of teased him a little bit about his age.
Yeah.
About not. I was like, I'm not going to ask you your age.
Yeah.
Because I'd heard.
Yeah.
And he says, I am 93 years old. And I was like, what? Why are you suddenly, proud and everything to say it? And he said that his son got angry with him one day. He's like, Dad, that is not something to be ashamed of. That's something you need to be proud of. You're fucking living until 93 years old. And you're getting by. You're flying airplanes, blah, blah, whatever,
Yeah, absolutely.
So, totally. With the age, you should be proud of it, I think.
I agree. I think it's, I don't know. That's one of the things, like with the more prevalence of social media and all the things you see on social media, and like celebrities, or whoever, like looking great at whatever age, and I wish they were more forthcoming about work they may, medications they may be on to help maintain their weight, surgeries, fillers and injectables and all that sort of stuff. And I wish they were more and I don't blame them for doing that. Their entire career depends on looking good. But I wish they were more forthcoming about what they've had done, or, and that sort of thing, so that those of us who can't afford it or don't have any interest in it, or, in any kind of those age-defying type procedures, didn't look at their photos of whoever at age 60 and think like, oh, geez, I didn't look that good at 20, I mean, it's anyway.
I noticed like the celebrities that I grew up with, you're kind of seeing like little odd, bumps in their cheeks kind of thing.
Right. And that's the thing. Like you can tell.
So so tell us about yourself. Where did you grow up?
Yes. So I grew up here in Wisconsin in a very small town called Rudolph, Wisconsin. It's just a little over 400 some people, but it's near Wisconsin Rapids, Stevens Point, the slightly larger towns that people.
Never heard of it.
You've never heard of
I've
Rudolph?
never heard of Rudolph. No.
The only reason people have ever heard of Rudolph is we have a really good cheese factory in Rudolph.
There you go.
And occasionally, depending on where you're driving, people have had occasion to drive through it.
Have you been to the cheese factory in Rudolph?
Yes, many times. It recently, it was owned by, privately owned for, a couple of generations and stuff, but recently was sold into, corporate hands. And so I think,
snagged it. Yeah.
So a little,
as often happens.
So and it's not quite as they're changing the kind of cheese that's made there. They're telling and it's not quite the same, but it's still good cheese.
That's good. So you grew up in Rudolph.
I grew up in Rudolph.
Went to high school in Rudolph.
Went to
doesn't
grade.
sound like they have a high school.
No, they used to. Like my dad went to Rudolph High School.
So this is like
way
a
back in the
family
day.
affair. I mean,
Yes, my dad's family has been in Rudolph going back 2 or 3 generations. My mom's parents, and actually my mom was born in Chicago, and they moved to Rudolph when she was about 7 or 8 years old. So, yeah.
So your mom and dad then met in Rudolph? Obviously, if she was 7 or 8, she didn't move to get married.
Yeah. No.
She's Amish.
Well, and so I went to a small grade school, Catholic grade school that was in Rudolph at the time, called St. Philip's. Yep. I mean, Polish, Dutch ancestry, mostly in the area, a lot of Catholics, a lot of Catholic farm families, a lot of big families.
Wisconsin.
So families with 10, 12 kids could support even in this small town, a Catholic grade school was supported. But then, when I was high school age, Rudolph did not have a hby school anymore. So we went to Wisconsin Rapids for high school.
You got bused?
Yeah. Sometime by the time I was I have 2 older brothers who were driving by the time I was in high school. So most of the time I got rides with them.
I had 2 older siblings too. So
yeah.
I got rides all the time. So, were you on a farm? You grew up on a farm? I mean, it seems like a really small town.
No, we did not live on a farm. My mom grew up on a farm, and my dad's, almost like everybody in his family, farmed, and so he sort of grew up on farms. But no, my mom was a nurse, and my dad worked in the local paper mill.
Okay, so is the motherly influence kind of the reason you got into healthcare?
Yeah. Yeah, I mean, it's interesting. In a small town, the nearest emergency department or whatever was, 15, 20 minutes away. And so for minor injuries or things, people often called my mom to have her come take a look and see. I mean, and she could, she didn't do stitches or anything, but she could steri-strip together a lot of injuries, and give people advice like, I can't fix this. You need to go to the emergency department or whatever, And so I, saw her do some of that, and, the way people asked her opinion. I think that was part of the appeal to me of like, hey, look at how you can help people, and, yeah.
So do you ever remember a time not wanting to be a doctor?
Not really. I think there were brief, I think I had my mind pretty well set on it by the time I was in high school. I think there were other brief moments where I was like, maybe I'd be a journalist, and I think if I had really focused on it in like high school and things, like I think I might have wanted to pursue music in some way.
Okay.
I was, but I was always interested in a lot of different things. So I never.
There's an artistic side.
Well, there is.
I can kind of see why you might have wanted to be a journalist.
Yeah.
Depending on the kind of journalism, right? You want to get the facts straight,
right.
or do you want to share your opinion?
Right. Those are both things I enjoy, getting the facts straight and telling people my opinions. But I think, so I think people could see me as a journalist. I think based on what people know about me now, I think more people would be more surprised about the music piece. But, but I was always so interested in doing so many different things in like grade school and high school that, I mean, I was in every club, and, I was not a great athlete, but played a couple of sports in high school, and I really didn't focus on the music in the way a lot of people who are going to pursue music as a career do, So especially now. But
so just an aside, I know you from as a longtime member of Crosse WI, where I attend as well, a coach.
Yeah.
And then Toni has been my first member of Freedom Meditation Studio, which is in front of this podcast studio.
Yes. Yeah. Yeah. I've been coming here to meditate. Depending on my schedule. I've tried, my goal typically is to be here about 3 times a week, but it's been a little more hit or miss at times than that.
Well, now that if you can't make it, you can always go online and find one of those really boring meditation videos. He's sitting there.
Right. This will help me meditate. Watching Scott meditate. Perfect. I think for me, it's harder to meditate at home. I have pets, and the second I sit down, they want to be, in my lap or, want attention and that sort of thing. And so
that's exactly why I opened the studio.
Right. Which is great. I, don't mind having pets who want attention, but it's when you're trying to meditate and you're like, okay, but I gotta pet this cat at the same time.
Or the dog. We've tried that at the studio.
We've tried the dog.
With your dog and with my dog.
Myra was a bit of a disaster.
And when I bring mine, there's just dog hair everywhere.
Yeah.
There's still dog hair from when I brought him like 3 months ago.
Yeah. I didn't mind when Buddha was here.
He's pretty calm.
Yeah,
he's
calm.
Dog, sure.
Unlike Myra, who's actually at home with just me, typically very calm, but new settings, new people. I think it's more even the new people.
I thought she was fun to have. I thought she was fun.
And
to be honest,
she's a sweet dog.
Nick said he's like, dog didn't bother me at all.
Well, yeah. I mean, we're all pet lovers, so
right.
Animal lovers.
Yeah.
So I think.
Yeah. How many animals do you have? 3 in your house?
How
many cats do you have now? Are you legally allowed to tell me?
I am not legally allowed to tell you. So I have a dog. I have 3 cats, and then my dad has 2 cats that spend a lot of time at my house.
Okay, there you go.
That's the official.
That's right.
Yeah. Mm-hmm.
Taking care of the dad animal situation.
Yeah, I would just like to clarify that I am an accidental 5-cat owner because, I took in an abandoned cat and who had a couple of kittens right before she was scheduled to be spayed. So, yeah.
So you still have those couple of kids?
Yes. I had tried I had tried to line up a couple of people to take the cats and thought, and I had certain criteria in my head. Like I wanted them to go to somebody I knew. I wanted them to go either together or not go I didn't want either of them to be a single cat, as I wanted them to go together potentially. And as I started, telling people sort of their restrictions and then, but it was funny, the people I work with, like the moment those kittens were born, they were like, you're never getting rid of those kittens. I'm like, no, my intention is somebody is going to take these kittens. They're like, you're never getting rid of these kittens. So
yeah, I fostered a dog once. Yeah. And I interviewed somebody and I'm like, this dog ain't going to hurt. There's no way. I was like, I'm not interviewing anybody else.
I feel that's how I would be if I ever fostered an animal. I'd just be like, I don't know. You seem nice, but you could be a serial killer. Right, so right. I think maybe this pet's better with me.
All right. So,
so I went to high school in Wisconsin Rapids.
Yeah.
And then college and medical school in Madison. University of Wisconsin. And then after that.
What was your undergrad in?
Biochemistry.
Okay.
Yeah.
And as a feeder basically into.
Yeah.
I hear when you take like pre-med, then it doesn't do you really any good because you're going to do med anyhow. So
right. It's interesting. Some places actually have pre-medicine majors. Like, okay, my whole goal is I want to go to medical school. A lot of places don't, at least when maybe that's changed, but at least when I was at University of Wisconsin, they didn't have a pre-med major. It was most medical schools have certain prerequisite classes you have to take in order to qualify to get into medical school. And as long as we had people in my medical school class who were music majors or things like that, but they just had to make sure they took all those science prerequit classes.
Electives or whatever.
Yeah, so they those were their electives so it makes for kind of a more well-rounded class, I suppose, than a bunch of people who are just pre-med majors.
If you were a music major, what would you be a specialist in?
Well, flute is what I played.
Flute.
I played piano.
Do you still have your flute?
I do. Yeah.
Do you practice it once in a great while?
Every once in a while.
Yeah.
And then when I pull it out, I always feel like I'm going to play this on a more regular basis. It's a very relaxing process for me. But then also, I will also reach a point where I'm like, and I haven't played regularly in 30 years, but I'll reach a point where I'm like, gee, I should be playing as well as I did. And back when I was in high school and was playing every day,
Right.
And
it's like when you do CrossFit and you go back
right.
and you're like, I should be able to lift this.
Right. So then I get frustrated, and then it becomes like a process of like, no, just step away from this for a moment. I just need to be more comfortable with just doing it for my enjoyment and relaxation at this point. Then, yeah. But I played piano from like ages 8 to 13, 5 years. But then just because of how busy I was in high school, just didn't continue it after. And that's,
busy with your other clubs?
Yeah. Busy with all the other clubs that had nothing to do with anything, and I wish I'd stuck out the piano playing,
We always do.
Yeah. That's
especially with the arts.
Yeah. That's one of my biggest regrets is because, you can't, playing a flute isn't helpful. Like,
no, I mean, but piano can take you.
Piano, you can, play lots of places.
And entertain family,
friends. Yeah.
Hey, friends, let me pull my flute out at a party.
I do it right. Yeah, listen to me. This will be Next music by Mozart. Sit back and enjoy, everyone. I briefly took up guitar. I have a guitar. I have a nice guitar, and for a while, there was a woman I worked with who was a music therapist who, as part of her job, like with the staff, was like, I'll do a group guitar lessons for anyone who's interested in learning guitar. So that was really nice, and I kind of got really into it for, once again about like 6 months or something, and then.
I have a guitar too. And
then set it down, and then haven't played for now it's probably like 5 years at this point. So, once again, it's sitting there and something I look at all the time and be like, I got to start playing that again.
It's frustrating too because TV takes the time, instead of practicing guitar, put on a stupid show.
That's exactly right. I get home from work in the evening.
I'll do it.
Yeah, kind of tired. Maybe I went to the gym or something, so maybe I don't even get home till 7 o'clock or whatever after work. And then I, eat something, and then I'm like, well, don't really have time to do anything else. I'll just put something on TV for a little bit and then drift off to bed. Yeah.
So speaking of TV, and video games.
Yeah. And video games.
And kids. So you said you work with a lot of teenagers.
Yes.
So let's talk about your job. I mean, what do you do as a physician? You specialize in something. What is it?
I specialize in pediatric hematology oncology. So I take care of.
Tell us what that is.
Yeah, I take care of kids and young adults with cancer and bleeding disorders and other blood problems. Yeah. So, and those specialties might sound a little weird that they're combined, but it's sort of a historical sort of thing because one of the more common malignancies is cancer of the blood. And so that's...
Which would be
leukemia.
Leukemia, which is a major kid-affected thing.
Right. That's, that leukemia is the most common cancer we see in kids. And so that's, kind of historically why that's a combined... Although it's combined on the adult side too, although people who take care of adults are much more likely to either do the oncology, like solid tumors, or the blood, cancer and blood issues. They sort of tend to divide it up a little bit more on the adult side. So, yeah.
Okay.
Yeah.
My friend that passed away was, he had an oncologist, but it was a blood cancer.
Yeah, I mean they'll typically still the training is still together for most people who doctors who take care of adult patients with cancer. The training for hematology and oncology is still combined, so they would also call themselves a hematologist, oncologist, and yeah. So yeah, but if I'm taking care of a patient who has a cancer, whether that's a blood cancer or not, I will tell them I'm an oncologist. If I have a patient, I will call myself their oncologist. If I'm taking care of a patient who has like a bleeding disorder, I'll say, I'm your hematologist. So, yeah.
Interesting.
It does scare some people, though, to come into our clinic because they think they're coming for iron deficiency and they realize they're in the kids' cancer clinic, And they're like, wait a minute.
Yeah.
We thought we were just here for
ask a lot of questions now.
Yeah. It kind of can raise the blood pressure a bit for some people until we explain what's going on. So
yeah. have you been in this same department, I guess, for many years, for all the 18 years that you've been with
Yeah.
So you've seen a lot of kids go through this situation.
Yes. Yeah.
So tell me, what kind of, have you noticed anything that like brings kids to, like, oh, it makes sense, you've been eating a lot of sugar? I mean, I don't know. Is there a family history or what?
Yeah, sometimes there's a family history. There certainly are some genetic predispositions that can lead to kids, why a child develops cancer, when typically we think of that more as a disease of old age, or at least older age. But the reality is, for most childhood cancers, most of the patients I see, it's not a hereditary issue. It's not environmental exposures. Like, we think of a lot of adult cancers as, maybe they were smoking for a while. Maybe their diet wasn't the greatest. The reality is people can do everything right and still develop cancer, But in the pediatric world, I would say that's especially true. Like, we don't really know any environmental, with some very specific exceptions. Like if they had some radiation exposure for whatever reason, we don't really know of environmental causes of any of the most common pediatric cancers, which is, obviously it'd be nice to know a specific cause, because then you can potentially help people eliminate it from their lives and reduce the incidence of cancers. But at the same time, when somebody comes in and their child has cancer, like, that reassurance of, this is not anything you did, this is not anything they did, I think is also, an important thing to be able to tell people.
It's pretty much just luck of the draw for most people.
It's pretty much luck of the draw. Like, so the thing about cancer and the way it develops is, so you have a normal, healthy cell. Like, I don't know, let's just go with a skin cell. Skin's cancer is fairly common. And your skin cells are still dividing fairly rapidly all the time throughout your life, okay? Anytime a cell in your body divides, there is a potential for a genetic mutation to occur in that cell. And you have certain systems in your body that's designed to correct those mutations, but that's not perfect. So we all, and especially as we get older, have a lot of cells in our body that have genetic mutations. And, it's maybe specific to that cell. But if a skin cell has a genetic mutation in it, any further cells if that skin cell that has that mutation divides, every cell that, arises from that initial cell with that initial genetic mutation is going to have that genetic mutation. And a lot of those genetic mutations are harmless. They're nothing. But sometimes they occur in genes that we would call either tumor suppressor tumor suppressor genes, which are genes that help fix the genetic mutations. Basically they occur in genes that help protect the body from those cells becoming cancerous and sort of having their division, switch always in the on position. So when a cell becomes cancerous, it's typically it's not that one cell itself is dangerous, is that cell thinks its job in life is only to divide and divide again and divide again and divide again. And so you get a tumor, as that cell just keeps continuously dividing. So, the reality is, yes, there are things you can do to reduce your risk of cancer over the course of your lifetime, because things like smoking, poor diet, too much sun exposure, things like that can increase your risk of cancer. We all have these mutations going on in our body all the time. And the theory basically is, if we all lived 100 plus years and something else didn't kill us first, everybody would probably eventually go on to develop a cancer, because, those mutations are constantly ongoing in your body.
Yeah.
So
when you eat poorly or don't exercise or get too much sun, whatever, that's sort of decreasing your body's natural ability to fight off those mutational cancers.
Yeah. I think there's probably a few different ways it happens. So something like sunlight directly on your skin increases those mutations that occur in your skin cells as they divide. So it increases the likelihood of you developing cancer in skin. Some other methods of things that can increase your risk of cancer would be things like, smoking. A lot of the dietary stuff may relate more to just levels of low levels of chronic inflammation in the body that kind of leads to those cells perhaps dividing or, trying to fix damaged cells. And the more frequently your cells divide, the higher risk for mutations. And so, I think there's issues like that.
like a daily dose of ibuprofen that reduces inflammation. I remember they used to have like aspirin, to keep the blood thinned out or something
they'll still do that for some people. Although I'm not sure exactly where the daily aspirin recommendations are at now. That's more of an adult medicine thing, but it thins aspirin and ibuprofen.
I just end up with nosebleeds all the time.
Well, right. It thins the blood. It makes your platelets, which are the blood cells that help your blood clot. Aspirin makes it less effective. It makes those platelets less effective. Aspirin, ibuprofen, Aleve, they're kind of all in the same family of medicines. Aspirin is kind of the most effective blood thinner in that family because it permanently disables the platelets you have in your system at that point in time, whereas some of the other... So platelets are replaced about every 7 days by your body, your blood cells. It's one of the most rapidly dividing types of cells you have in your... one of the most rapidly dividing types of cells you have in your body. And aspirin, you take an aspirin, those platelets are going to be less effective until they're done and, die and replaced. Whereas you take a dose of ibuprofen, it's a reversible effect on the platelets. So once the ibuprofen effect wears off 6 to 8 hours later, those platelets go back to functioning normally. Well, that was really a tangent, wasn't it?
What do platelets do?
So, yeah, platelets.
I remember, don't they like block platelets?
Yeah, that's basically exactly it. They're the blood cell that helps your blood clot. So, if you've got a scab, an injury, a big part of that scab is going to be a bunch of platelets clumped together. There's other proteins and things in there as well, but a big part of it is those platelets. And they secrete some things that then help bring, the other things that help form the clot to the area. But that's platelets' main job. They help your blood clot. Sometimes that's a good thing. You get a cut, you get a scrape. Yeah, you want to stop bleeding. Sometimes your platelets, form clots in places they're not supposed to, or they play a role in forming clots where they're not supposed to, and you get things like DVTs or blood clots in the legs or the lungs or things where they're not supposed to be. So,
gotcha. So that's how aspirin would help. Okay.
Yeah, so that's how aspirin can help in those situations and prevent those sort of things. Yeah,
move out of the body through waste or whatever.
Yeah. Platelets. Yeah. So your old blood cells that are aged and usually a little bit damaged by the time they're to the end of their lifespan, they're generally cleared by your spleen.
What's the lifespan of a blood cell?
So
we're really tangenting.
This is
I don't know this stuff.
So a typical white blood cell, and there's many different types of white blood cells. Excuse me. Yeah. But a typical white blood cell is only in your system for a day or two, or like 24 hours. Okay. So white blood cells are really rapidly being created and being removed from the system. Red blood cells, so that's what the hemoglobin is in and carries oxygen around to the rest of your body. So that's what gives you energy. That's, people who have low red blood cells or low hemoglobin are tired, pale, cold all the time, those sorts of symptoms.
I must have that issue in the afternoons in the studio. I get really cold.
Yeah. Men it's a very different thing with men, but 40% of menstruating people are iron deficient. So mostly obviously talking about women. So, and young women. And so, you need iron to make hemoglobin and to fill your red blood cells. So a lot of people are iron deficient and don't realize it and have symptoms that relate to it. But red blood cells last in your system for about 3 months. So they're the longest lasting of the blood cells. And platelets, and then platelets, as I mentioned, last about 7 days. So
you're talking about iron deficiency.
Yeah.
So supplements. There was some study I remember 20 years ago or something that said, maybe it was 10 years ago. I don't know. Supplements don't work. They just get peed out of the body or whatever. But
it depends on what supplement you're taking and what the purpose is. I think iron supplements are probably one of the few supplements that, at least in certain, menstruating individuals, iron supplements could benefit a lot of young women. Okay. The problem is oral iron supplements have some potential side effects. Most people tolerate them just fine, but taking iron orally at doses that are actually going to help you can cause constipation, can cause nausea, worsening of acid reflux type symptoms. So, I wouldn't necessarily recommend someone to just start taking it if they don't need it, because it does have some potential side effects. But at the same time, a lot of menstruating individuals would need an iron supplementation. So I think clearly, my recommendation would be for a lot of young women, just go on an iron supplement.
Especially if you're not eating leafy greens.
Right. So red meat has the highest concentration of iron and is the most readily absorbed iron that you can get in your diet. There certainly is plenty of iron in things like green leafy vegetables and many other foods. It can be a little bit tougher to absorb. And then some other things we consume may decrease our absorption of iron. Things with caffeine can limit the absorption of iron. So if you're eating iron, but you always drink a lot of coffee whenever you're eating an iron-rich food, it may limit your absorption of the iron. So, and the other issue too, there's all sorts of things that can interfere with the absorption of iron in our body. Like if you have acid reflux and are on Pepcid or Protonix or something like that, iron to be absorbed likes the more acidic environment. So if you've got those things that are functioning as acid reducers, that can inhibit your absorption of iron. So there's a lot of different reasons why people run into trouble with iron. in which case a supplement may actually help. I think your statement of like, well, supplements don't help is
wait. Help. I didn't say that. I said, wasn't there a study of like 10 or 20 years ago that said that?
And I think there's always a little bit of conflicting evidence about it. Like, I think in general, the data has shown like a multivitamin doesn't provide most people any benefit unless you've got some specific dietary restriction and know, some things you might be low on. Like taking a multivitamin is not going to benefit most people. I think a lot of
the D.
Yes, vitamin so iron and vitamin D are the things we most strongly usually end up recommending for our patients. Especially like here in Wisconsin, because because
we never see the sun.
We never see the sun, or
I remember when I was growing up, it was like 7th grade or something like that. I raised my hand. We were talking about weather and seasons and everything, and I raised my hand. I was like, "Does the sun ever shine in winter?" And everybody laughed.
It's sunny.
But then the teacher
today.
said, "No, that's a good question."
Yeah. It's sunny today, but of course, who's going to be out not completely covered when it's only like 20 degrees out? So. Yeah, so that's the problem. In the winter, the sunny days tend to be the really cold days.
Right.
Anyway.
Plus, it's only like from 8 to 4.
Right. So you've got that little stretch where you can go, and anyway.
So let's go back to your. God, there's an echo. I need to get rid of that.
Yeah.
Your job.
Yeah.
So when you come back
off these tangents.
Yeah. When you accept people in, people come to you for the first time.
Yep.
First of all, have they been diagnosed already before they see you, or are they seeing you and you're doing the tests, or is that already done?
Right. Sometimes they've already been diagnosed. Sometimes
obviously their primary care physician has probably said, "All right, you need to see a specialist."
Right. And they may have, generally speaking, even if the final official diagnosis hasn't been made yet, they're like, "We're going to send you to see, the pediatric oncologist, the cancer doctor," and it's because
or the hematologist,
and it's because this looks, work, and typically the primary care provider or whoever, sometimes these patients have sudden onsets of symptoms and they're seen in the emergency department, but they will usually suggest like, "We are worried this could be leukemia. We are worried this could be, and that's why you need to see the specialist."
And they're generally showing signs of what when that would happen? And say it's leukemia.
Yeah. So leukemia is a cancer of the blood. And it
just basic terms. What are we seeing?
Yeah. So leukemia is a cancer of the blood. And so what happens with leukemia is that it was a blood cell that started rapidly dividing. And so instead of getting a tumor, like you might get, like if somebody had kidney cancer, and they get a big, ball of something on their kidney, it's just the bone marrow, which is where our blood cells are made, gets replaced by these leukemia cells. And they're not making normal blood cells. They're just making these more and more leukemia cells that don't function as normal blood cells. And there's a few different types of leukemia. We don't need to get into any kind of details about that. But, typically these are very early sort of blood cells that can't function as a white blood cell or a red blood cell or a platelet. So what happens in the way people present when they have leukemia is their bone marrow is not making normal blood cells. So they show up with the symptoms of anemia, really low hemoglobin. So they may be pale, no energy, headaches, get lightheaded, They may show up with symptoms of the low platelet count, which is so like we talked about the
bleeding.
Yeah. So easy bruising, covered in bruises, bleeding symptoms, nosebleeds, young women may have, their periods might be a lot heavier than they were before, that sort of thing. But the leukemia itself can also cause some symptoms, like fevers, because the bone marrow, which is, of course, in the bone, is packed with leukemia cells. They often present with pain, with bone pain. And so those are some of the most common things we see when people show up. And they'll have some findings when you do an exam, like they often have, big lymph nodes or glands, as a lot of time we call them when they swell up. When you have a sore throat or something, they'll have big lymph nodes throughout their body, not just like, in their neck. Their liver and spleen are usually big when we examine them. Not always, but
so they come to you.
Yep.
You confirm what it is.
Yep.
And then recommend a plan.
Yes. Yeah. So the diagnosis, of any cancer, you're usually going to have to do a biopsy of some kind or other. So even if somebody shows up with, say it's a 4-year-old who shows up with a tumor on their kidney. There's a kind of tumor called Wilms tumor that is by far the most common kidney cancer we see in kids. And it's almost always going to be that. So there's very rare situations where we may say the safer thing to do is to just start treatment for that. But in most situations, you're not 100% sure of where, what the diagnosis is. And so, it may involve a surgery trying to remove the full tumor if it's a solid tumor somewhere, or it may just involve a biopsy depending on sort of what how accessible the tumor is.
So
to
this has
resection
got to be.
and
I'm gonna
things like
get like down to like personal stuff now. This has got to be like challenging for you to tell the parents about, and sometimes if they're older kids, to tell the kids. You said some young adults.
Yeah.
You work with.
Yeah. It is that initial, I think, phase of we're trying to figure out what exactly this is. We got to take this a step at a time. I think that's, for me, in some ways, unless a patient is not responding to therapy and we think they maybe are going to pass away, that's obviously like the hardest part of my job. But I think as far as when it comes to, telling them and coming up with a treatment plan, that sort of waiting period while we're going to trying to figure out what it is and come to the family with a treatment plan is always sort of the hardest, because there are days when you have to like talk to the family and be like, I still don't know, don't have any final answers.
And I hear that's the hardest part for patients too. It's like
I think
that sort of holding period, like, okay, something's going on. They're trying to figure it out. I don't know what's going on.
Right. I think that's very true. I have had families tell me that the not knowing is the hardest part. And
I heard some people talking about it on a show I was listening to.
Yeah.
At some point.
And it does feel like there is a sense of relief when I can go in and say, okay, this is what it is. This is how we're going to attack it. This is, now we can start we've identified the problem. Now we can start fixing it. I think that waiting period of, I'm not even 100% sure what it is. And so I can't, I can't give you a plan as always.
How often, once it gets to you, how often is it a cancer?
Oh, but usually I would say,
I mean,
probably.
How often do you get to tell them great news right off the bat?
Yeah. I mean, it might be higher than you think. It's probably, because I get some consults that are like, oh, somebody's had, a kiddo's had a big swollen lymph node in their neck for, they had a cold, it got big, lymph nodes swell up all the time, but obviously, typically after an infection, they go back down to normal size within, at least a few months. Sometimes when those lymph nodes persist, I'll get those consults that are like, hey, this lymph node's not getting smaller. Maybe it's even gotten a little bigger where, the family's not sure, blah, blah, blah. Maybe there's some other stuff going on, like the kid's tired all the time because, everybody's tired all the time. And then,
especially since COVID.
Right. And as soon as you ask somebody, well, how's your energy level? Now are you, right. And then they'll be like, well, now that you mention it, I am. Yeah. Anyway. So, there is some family sometimes when I can just offer reassurance and be like, this isn't, a malignancy, but it's tough to tell on exam. Like you can, so often families, even if it's just, I'm 90% sure this is, or 99% sure this isn't a malignancy, but you've been dealing with it for a while. There's some other symptoms going on. For your reassurance, it's probably a fairly simple thing to, get a piece of this. And, so I get those consults not infrequently, but I would say, and occasionally, even when it's in pediatrics, and this is probably true in the adult, oncology world as well, they'll have tumors that are, maybe they're even a malignancy, but it's just treated with surgical removal. And so then, that's essentially good news because it's like, okay, you had the surgery. Yeah, we have to do some monitoring scans and stuff going forward, but there's a less than 5% chance this is coming back. And,
and a lot, some of that time you don't even need like chemotherapy or radiation.
Right. Yeah. Once you get it out, there's certain tumors that it's like you take it out. Certainly, I mean, that's what we would call, certainly that's the case with what are benign tumors or not. Benign just basically means there's not risk of it spreading to other parts of the body.
Yeah.
Benign tumors can cause a lot of problems depending on where they're located. If it's pushing on, your kidney, pushing on your, intestines. And certainly if you've got a benign tumor in your head, they can still cause a lot of problems. But if it can be taken out surgically, then you typically don't need to do any further chemo. You're exactly right. Chemo or radiation, which is the typical arsenal of treatments that I
So the
can
malignant
recommend.
ones generally spread
Or
through
yes, or are capable of spreading
through the blood,
spread through blood and the lymphatic lymphatics system. Yeah.
It's the Hemopro Dr. O.
Yeah.
I forget the word.
Right. Yeah. There are some blood tests out there now, sort of screening. Yeah, can do some screening for cancer. I'll be honest, it hasn't really made its way into the pediatrics world at this point. So I'm not, we certainly don't do any screening in pediatrics with it. And we haven't really started using it routinely to monitor patients, at least in my patient population. But I think, people are looking at that, but we haven't
So 18
started
years,
using that routinely.
That would bring you to 2006-ish when you...
Yes.
Have you noticed a difference in what kids are coming in for in the last 18 years?
Not in what kids are coming in for.
The amount of kids.
I see a lot more iron deficiency than I used to, but I don't think it's because iron deficiency is becoming any more prevalent. I think it's because we have started doing more for patients who don't tolerate oral iron, don't seem to respond to it for a variety of reasons.
Oral iron meaning supplements.
Yes, taking a supplement. We have started doing IV infusions of iron much more frequently. And sometimes it's just, they're just not taking their oral iron,
Right.
and it's like,
You're paying my ass, kid.
it does feel a little bit like that from time to time. So
You're causing our healthcare coverage to increase.
Well, exactly. You just want to just take your iron, if you could just take your iron. And sometimes they're very honest about it. They're like, I just forget, and you're like, come on, set an alarm. I don't know. Fix the problem. Anyway.
Yeah. Do you have your phone here? Let me just...
Yeah, right.
Let's
set an alarm. Here's your iron alarm. Anyway, other than that, I don't know that I'm seeing a ton of different things or that we're seeing more of certain cancers or whatever. I think the biggest change I feel like we've seen is we see more people now who question. I don't have question, but want to try naturopath, something natural first, or want to do, want to try other things first, or,
change their diet, listen
if I
to
change my diet, right? There are these programs out there who, detox supplement programs, that people are like, well, we want to try this first, and to be honest, in certain pediatric cancers, in the past, it was an easy thing. If a family said, we don't want to treat this, and for whatever reason, or we don't want to follow your recommendations, and it was a cure, a cancer, it was like, but we can cure this like 90% of the time. It was a, Child Protective Services referral, and CPS would basically say, you have to treat your child. Now, what I've seen in a couple of cases is the parents made the argument like, well, we are doing something. We're doing, these diet, this doctor, which may be a chiropractor, maybe a naturopath who's,
maybe a witch doctor.
They made this recommendation and we're following their recommendations. And so we've had a couple of cases where CPS has sort of basically said, well, they're doing something, and
recently, more so.
That I would say that's something that we see a lot more of recently. And even in families where they're perfectly happy to follow our recommendations, there's okay, but what about this supplement? What about ashwagandha? What about, what about alkalinized water? I saw this thing that says that treats cancer, alkalinized water,
one TikTok search these days, so you get all sorts of.
Right. And I think, some of the stuff is, the reality is, a lot of that stuff, we just don't have the data to be able to say it may not be harmful in a typical setting, but we don't necessarily have all the data we would love to have to say, does this interact with the chemo we're prescribing? Does it maybe decrease it? Is it maybe you taking that supplement going to increase your side effects from, certain medicines? But in general, I think the reason people fear cancer so much is it is completely out of your control, right? But people are just looking for any sense of, I have control over this. Look, I learned about this. I learned that this might help my child, or if it's a young adult, I learned that this might help myself, and so I want to.
Just grabbing at anything.
They're grabbing at anything.
While you guys are trying to run a legitimate healthcare facility and go on based on science and
right. And I think if I can find information that says like this is safe, and not going to interfere with what we're trying to do. Too often, I will sort of tell people like, look, I don't know that there's any benefit there, but if you feel like there may be some benefit for you, I'm fine with it. And I try to take that approach.
Of course, you have the placebo effect too. So if you you think it's helping, and as long as it's not going to harm with what we're doing here to
So I feel like there's a lot more of that as far as the immediate like patient interactions. There's a lot more of that, like people coming in with I did my own research and this is, and I mean, some of it, there may be some.
It's the information age, man.
It feels to me like we have all the information in the world that are literally at our fingertips, and yet it still somehow feels like we're entering the dark ages into another dark age. It just is. It's so
it's interesting
weird.
That every time you do a search nowadays, AI gives you their opinion, based on everything they've read.
Yeah,
they read a lot of shit.
Right. I have this theory about AI that that it may. So one of Elon Musk's companies, and he has a bunch, he's like CEO of like 6 or 7 companies, right? Which tells you what CEOs actually do, which is, if you have the time to be CEO of 6 companies, you're not doing much for any of those companies. But so one of them has an AI that they're developing, and it was asked, like, who spreads the most misinformation on social media? And the Elon Musk's company's AI identified him as one of the biggest spreaders of misinformation on social media. And I sort of have this theory that because most of the CEOs, the heads of...
He's probably an alien.
Most of the CEOs, they're going for the bottom line. Like, they're not necessarily going for the good of humanity or whatever. Like, they're going for the good of their companies. But AI is going to provide information to people that's going to be like, climate change is real, and some of this other stuff that's...
You mean
the powers that be are not going to really, want to be what, because then they're going to start saying, well, AI is maybe not, that's AI's opinion, which, AI doesn't have an opinion. AI functions with facts. But I think as soon as AI starts putting forth information that is contrary to what these oligarchs, basically CEOs, billionaires, want us to believe, I think there's this is just a theory, but I think AI is going to be quashed to a certain extent.
They had to quash a recent AI who tried to stay alive by lying and cheating, apparently.
Oh, there's some scary stuff about AI. Yeah,
like anything I've read, though, it seems like the AI usually says, well, there's differing opinions on it. It's kind of like how they don't make one statement. Some people believe that this and some people believe that. It kind of like balance the, I don't know.
Yeah, I don't know.
But apparently this AI was given directives like stay alive at all costs or something like that. Complete this directive at all costs. And then it started like lying and like trying as soon as it realized it was going to be like replaced by a new AI. It tried lying and stuff. To stay alive. So I don't know who's programming it to stay alive at all costs.
Right. Yeah.
That's pretty scary.
That seems like where Terminator movies started. Like somebody was like, your existence is the most important thing.
Right.
Yeah.
Right. Let's take a pause.
Okay.
I'm going to go to the bathroom and then probably stop and restart this. So we have one more 30. We're back. Thanks for letting that happen. So one of the things I think would be great for these kids who are dealing with cancer and their parents and family members is to perhaps integrate a meditation practice.
This was a smooth segue.
Do you tell people that you have a meditation practice?
The people I work with know.
No, you don't tell them, or no, K-N-O-W?
No, they K-N-O-W. They know that I've been meditating. I haven't necessarily told any patients. I have occasionally, and I don't know that I go into specifics, but when we've got a patient where it's like, relaxation, you need to coping mechanisms for dealing with anxiety or for relaxing or find it, have suggested, meditation and, along with some other recommendations. But
did you know there's a great meditation
studio? And did
you're probably like, stay the hell out of my meditation studio. I don't want to see my patients.
There may be, look, I love my patients. I don't mind, but there is a little bit of an element of when I run into this is a small town. I run into them, can run into them anywhere, and you just, you sort of, there is a little, I leave it up to them typically if they want to approach me and say hi, because it's not appropriate for me to be going up to them and,
as a physician,
a physician being like, hey,
I remember when
how
I was
you
a
feeling?
teacher. When I was a teacher, I'd be like, I don't want to see any of my kids at the grocery store or anything.
No, I mean, I think it, yeah.
Definitely not at the gym or whatever.
Right. I mean, it does. Yeah. It just leads to whole other issues of like, anyway.
Privacy.
Blah, blah, blah. And, I mean.
Sued because I said, hey, how's your condition?
Right. Having any side effects from that medicine I prescribed yesterday? How's that going? And,
she talked really loud in the grocery store. Right. I swear my girlfriend heard.
Right. Yeah.
Has anything like that ever happened to you?
No, I mean, I've run into patients in the grocery store and.
No, have you ever been sued or anything by?
No. The one time this is sort of a funny story. I was named in a lawsuit. I was still in medical school. And at the beginning,
great start,
right. What's going on? No, but so one of them, I went to medical school at the University of Wisconsin where they do a lot of.
We've already been through that.
Yeah, let me just anyway.
Sorry, where they do a lot of what?
They do a lot of organ transplants.
Oh,
and. So when you were on a surgery rotation, one of the big things was, hey, I got to be in for a liver transplant for a while. Although anyway, but this isn't okay. Edit this part out. I was on a surgery rotation.
No
I was on my surgery rotation, I think right at the start of my 4th year of medical school, or maybe towards the end of 3rd year, it doesn't matter. And I went into the OR for this procedure, and it was the individual
operating room.
The individual had what's a dissecting aortic aneurysm. Okay,
dissecting aortic aneurysm.
So to explain that, it's your aorta is the major blood vessel that carries blood from your heart down to the rest of your body. Like it's a huge, artery.
To the story.
It is because as I'm explaining what this is, but. In certain situations, triggered mostly by really high blood pressure or issues, the wall of this blood vessel, the aorta, can actually sort of split away from, the very out. So you get sort of like a, it basically
bulges and then it
basically blocks off the flow of blood through your aorta because you've got part of the lining of the aorta falling into the blood vessel itself.
Mm-hmm.
Okay.
Mm-hmm.
So this individual, it was likely triggered by high blood pressure due to his cocaine use, had a dissecting aortic aneurysm. And you have to repair that immediately.
That, kids.
Don't do cocaine. In case you thought it was a good idea, don't do cocaine. So you have to do surgery immediately or else they're going to die. They're going to have paralysis of, the lower extremities because
flap. So
we need to get blood flow restored to the lower body. I was in the operating room, OR, for about, 10 minutes while they were trying to they didn't want to, because of the tenuous nature of this patient, they didn't want to do general anesthesia, put him fully to sleep. But you can do epidural block, the nerve receptors where the surgery actually needs to be performed. And so they were trying to do a lumbar puncture to get, to start infusing those anesthesia medications and directly into the spinal cord and make him numb from the waist down, basically, so they could do the surgery. So they were struggling to get the LP to do that procedure. But that's all they were doing the entire time I was in the operating room.
Propane, the LP.
LP, lumbar puncture.
Okay.
Spinal tap is the other name for that. So I was in there for 10 minutes while they were trying to do the lumbar puncture, and it never really happened. And then I had to go to like a lecture at noon. Like that was our priority. Like
that's all time you spent in the OR.
That was all the time I
10
spent.
Minutes and then,
yeah, and then I left.
Was the person like screaming while you were there because it hurts trying to do that?
And no, I mean LPs aren't that painful. That usually numb it up. Like I mean, he had a lot going on, but he wasn't screaming or anything like that.
And he was on coke.
Well, yeah. Anyway. Literally, I don't know. It was definitely like close to 6 months later, I get this letter that says I've been named in a lawsuit, and it was for this particular patient. And the outcome was he ended up paralyzed from the waist down, and he was telling people, and he said, well, you never told me that was a risk of the procedure, was the claim. And I immediately called, I got that letter literally a day or two before I was supposed to graduate from medical school. And I just was, you can imagine, in a panic. Yeah. Like, I'm like, sure. What does this mean? What is for my career? What is this, whatever. I got to start listing this on anytime I want to get licensed and explain it. Yeah. And then I called.
They do ask you that stuff in the application.
Yeah, and every time we want to be re-credentialed or our licensing comes up for redoing, that's not the word I'm looking for. Recertification. Yeah, we have to, you get asked, like, have you been named,
Right.
Yeah.
Even as an insurance salesman,
right.
You have to answer that question.
Right. So anyway, so I called, I don't know, somebody at the medical school I thought could help me. And they were like, well, there's a time limit, and it's often like 6 months for certain things before, within which they have to file. They have to file
or something.
Right. And what they do is they just literally go through the chart. And if your name is on the chart, you're, included in the initial paperwork so that, they don't miss somebody, when they actually end up filing it. And then of course, I don't know if it ever even went to trial, I'll be honest, because I never heard any more about it. I'm assuming it's
that's scary, yeah.
Yeah, but I mean, they had me listed as Dr. Toni Peters, which I was not a doctor at the time. Like, anytime somebody walks into the operating room, somebody has to record that they're in the room. And so my name was on the chart.
Did they have you listed as Dr. Toni Peters or Dr. Antoinette Peters?
I don't remember.
Bringing it back.
I don't remember. Yeah, it is funny that anything legal, I sign Antoinette. It's, my legal name, but yeah.
So what's the funny part of that story?
Well, no.
It was kind of funny.
Well, it just how panicked I was at the time. Like I was, and then it was just like, it was just, I had nothing to do with it. And it was, looking back at it, I sort of laugh about it. That's why I say it's funny.
Ever try to sue you since?
No, not that I know of. I have been deposed once when somebody else was being sued, but that was just stressful, even though it wasn't really me. But
Yeah.
Anyway.
So in 18 years, you must be pretty good at communicating and certain. I mean, you probably deal with very similar cancers.
Yeah.
Throughout I mean, how many per month? How many new cancer?
Yeah, I mean, we are a smaller program.
You serve about probably a community of 200,000 people.
Yeah, I mean, we're Western Wisconsin, particularly southwestern Wisconsin, up to some, central Wisconsin. We get some patients from up in that neck of the woods. Eastern Minnesota, to a certain extent.
Tightly eastern Minnesota.
Yeah, fairly tightly.
Any further, generally would be Rochester.
You would be surprised by the number. I mean, it's not a huge number, but we've had several patients over the years who live fairly close to Mayo Rochester and prefer coming to Gundersen for a variety of reasons. Like if their insurance allows it. I mean, I think Gundersen's a little bit smaller and easier to navigate, and I mean, there's a few reasons.
I guess you're right. Personal care is probably a little bit easier to find.
Yeah. So, and then down into Iowa, we get some patients from Iowa. as northeast Iowa as well. So yeah, couple 100,000 catchment area. We get, and because we are a smaller program, we get, I don't know, it seems to vary greatly from year to year, but I would say as far as oncology cancer patients, we get, where we actually have to do treatment, 6 to 15 new patients per year. Like I said, it seems like it varies widely. Like we've had years with very few patients and then years where, it is like, every couple of weeks a new patient for a stretch. Mm-hmm. So, yeah.
So generally in your staying overnight in the hospital, the
patients?
Yeah.
Yes. Well, it depends. So, it depends what kind of cancer they have and how they present. So some patients, like Hodgkin's lymphoma or other types of lymphoma is also fairly common in the pediatric world. Some of the, so if they're diagnosed by, a swollen node in their neck or chest or whatever, they don't necessarily, like Hodgkin's lymphoma we treat fairly commonly, and they would literally have to spend no time in the hospital typically unless they have some unexpected side effect of their therapy. Leukemia patients typically are going to spend, and once again, it depends a little bit on the type of leukemia and all that sort of stuff, but they're at least going to spend some time in the hospital. A lot of times at diagnosis, even before we make that diagnosis, a leukemia patient will be in the hospital while they're pretty sick, their blood counts are low, they're maybe needing transfusions. And then when we start treatment, they're usually in the hospital for a little bit longer as well. AML, which is a type of leukemia as well, acute myeloid leukemia. Most pediatric leukemias are acute lymphoid leukemia. But the AML, we have to treat a little differently, a little more aggressively, and those patients can spend like almost 6 months, almost entirely in the hospital getting that treatment. So it really varies, how much time somebody's going to spend in the hospital, even what their treatment's going to look like, how aggressive the treatment is going to be. It varies so much from cancer to cancer that it's, tough to even sort of give you a generalization. But because ALL or leukemias are the most common cancer we treat, most of our patients will spend at least some time in the hospital. Yeah.
Are there some times where you don't have any patients?
In the hospital,
I guess have there been some time?
Yes, we have gotten busier over the 18 years that I've been here. I would say that was a more common, 10 years ago that we'd have stretches with no patients in the hospital. I think the last 5 years or so, most of the time we have a patient in the hospital. So, yeah.
So you've
at least a patient. Yeah.
Communicating with the family, not so good news here and there.
Yeah. Yeah. I mean, like we were kind of discussing earlier, sometimes they come in knowing that sometimes the diagnosis is already confirmed. They were sent to surgery before they were sent to me. So the biopsy or, tumor removal is already done. And so then I see them and we already have a diagnosis. And sometimes, yes, I see them sort of before the diagnosis is made and I'm part of the workup. And then I do have to give that news of, yes, it's, it is cancer. But I think like we were talking about earlier, often as we're going through that workup process, it's been made clear to the families, the patient and the family, cancer is a possibility, that's why we're doing all this, and so I think it is hard, obviously, to give that news, okay, this is what this is the thing we really didn't want to hear, but this is what it is. But that, like I said earlier, there is that little bit of relief of, well, at least now we know what it is and we can start treating, so, yeah. But it's,
Do you guys still do the whole thing? Because, when Maggie had hers, she went in and they said like 13 to 30 months. Is that generally what, if it's a terminal sort of thing, you guys would need to do still? Or
we don't have fortunately for us in the pediatric oncology world, we don't have too many tumors that we treat that are clearly, terminal, and we're dealing with a time frame. Okay. More, that's much more common on the adult side, where they'll sort of, have to say like, we can do treatment that'll give you more time, but most people with this type of tumor are going to be, are going to pass away within, 2 years or whatever. Just, people got to know, you're not doing anybody, as hard as it is to tell somebody that, you're not doing anybody any favors by hiding that information.
Yeah.
Most of our pediatric patients, there is a treatment, and generally the most likely outcome is going to be a cure. We cure over 80% of all pediatric cancers. Obviously that varies a lot depending on what the tumor is, how, if it's spread, that sort of thing. But most of the time, I get to, what I say when I go in is, okay, this sucks, but we can treat it. Most likely outcome is we're going to cure it. And, that doesn't mean it's going to be easy. Like the treatments can be really difficult, but, hopefully 5 years, this is all going to be a bad memory,
Yeah. It's interesting that you said that you start with this sucks.
Well, it does.
When I had when I had to say bye to my first ever dog.
Yeah.
The best thing somebody ever said to me, it was Sarah Friend. That was her name, Sarah Friend, and a friend of mine. But she said, God, that sucks. Because she had been through it, a year prior or whatever. But my condolences. Oh, I'm so sorry for you. Blah, 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 blah. You can hear that. You can hear that. You can hear that. You can hear that. And it's okay, whatever. But when she said that sucks, I knew she fucking got it.
No, and now
I got to edit that out.
Right. Well, I think sometimes I do get the question, and I maybe am not the best person to ask this because I haven't had to go through the treatment. I haven't been diagnosed with cancer, but people will ask like, what can I do for if somebody I know is diagnosed with cancer, or what can I say to them? And I think just acknowledging that it sucks, that it's awful, that it's acknowledging that it's unfair,
spot on,
And I think to a certain extent, obviously what you're going to say to somebody depends on how well you know them, how well you know their belief system and things like that. But we have had families.
But regardless of how well you know them,
right.
It still sucks.
It's still, that's always a good place to start.
Right.
But we've had, families who will tell us like, somebody, especially once again with social media and, if people are commenting on, people will put out information about, hey, look, I've had this diagnosis or whatever. And the comments people will get back will be like, maybe even from somebody they don't really know, will be things like, well, God has a plan, or,
proud of you for fighting. You're so strong.
Right.
You're so strong, right?
Yeah, you got this, and I think in certain situations, once again, depending on how well you know the person, and in certain situations, and if you know somebody's religious beliefs, like, okay, maybe that can be helpful. But I think just generally your safest thing to do is just acknowledge this sucks.
So you've lost your fair share of
Yep.
sorry to go there now.
Yeah.
But we're winding down here. We got shoot. I got to get that camera looked at in 20 minutes. So we got like 10. And you know that I am very interested in like hospice care nurses and what they have seen people who are dying go through as they're dying.
Yeah.
Any kids chit-chatting with relatives when they're about to go?
I have heard some stories similar, along that lines of like kids who said something, talking to grandma or something, grandma who had passed away a few years earlier or something. And this was before I started at Gundersen, but there were a young adult passed away, but she was fairly close with some other individuals in the or some of the younger kids. Like, she was the type of young adult who wanted to work with kids, and she was had become very close with some of the younger kids going through treatment in our clinic. These kids, they were there at the same time, or so they met each other and knew each other. And one of the younger, as this young adult was, getting close to passing, apparently one of the younger kids, out of the blue, kind of said to her mom, like, "We need to go visit her. I think, I feel like we need to go see her." And it was, and they were able to visit her within hours of her passing, kind of thing. So, and they hadn't really been telling this little kiddo what was going on,
the kid was out of the hospital at that point.
Yeah. They were at home, and she just, I think, the parents maybe knew, that this other, young lady was in the hospital and things weren't going well, but, didn't necessarily know things were imminent. And, and then kind of out of the blue, this little child was like, we need to go visit her. Yeah. So
I would like to invite you on another time, and we can get more, now that we know where you come from and what you do.
Yeah.
We could get more into the nitty gritty of where we're going.
Yeah. Yeah. I think it's, I don't know how much you want to talk about we need to wrap things up, but I think it's when treatment is failing in kids, and it becomes obvious we're not going to cure this, it's a very different, not always, but it's a different process that it often is for adults, especially if the adult is 80,
older,
and they're like, "Oh, we had a good run," kind of thing. I mean, not that it's ever easy. I didn't mean to minimize that, but
to think that perhaps they were here for a purpose, and their purpose was a short term.
Yeah. I mean, I think the interesting thing about pediatric cancer is that the kids who pass away quite young, their even short existence, I would say, sometimes feels to me like it has more impact on the world around them than some people I know who've lived long, full lives. You know what I mean?
Had any kids or many kids that kind of knew that their life was going to be a short one? I've heard of that happen.
I don't know that any of them have not that I've ever had expressed directly to me. I think when we've had situations where the cancer, like, we as the providers know we don't have any curative options left to offer you. And we've, had that discussion with the parents, depending on the child's age, depending on their, whatever. Parents often are like, we don't want them to know. We don't, or we don't want them to know yet. We'll wait. And I think my experience and the experience of the people I work with has generally been, they know. I mean, they're the ones, this is playing out in their body. They know when they're not, they know what they feel like when they're sick versus when, maybe their cancer is in remission and they're feeling well. And, and my experience has been, they know. And you see, I mean, every time is different, but you potentially see some unique behaviors. Some kids will actually start acting out, pushing their family away, thinking like maybe they won't. This won't be as hard on them when I pass. If I was a pain in the ass for the last 3 months, they won't miss me as much. They'll just be relieved. And other, and it's. Obviously, with kids, often the situation is, as a parent, and I'm not a parent, but I think for a lot of the parents, they need to feel like we did everything. We made every attempt. And whereas that might be a little bit different in the adult world, an adult making decisions for themselves may say, I've had enough of this. I'm done. I think in the pediatric world, it's, no parent wants to be in that position of 6 months after their child passes, sort of thinking, oh, if only we'd tried that clinical trial that they told us, wasn't likely to work, but who knows, maybe, so parents don't want to be in that position. So they'll often, kind of keep looking for that. What's the next thing? What's the next thing? And that's when it gets really tough, is when you have to be like, there's not a next thing, this is, and I think sometimes parents, the best, I mean, there's no good way to tell people like we don't have good options for treating their child anymore. But I think the best phrase I've ever found is, we need to think about at what point are we not doing things for your child? We're just doing things to your child.
Yeah, and for you.
Right, or doing things for you,
right.
And not, it's not for the child. We're just doing things to the child at this point, and nothing we're doing is going to, maybe it gives them a few more days, a few more weeks, but what is the quality of that time? And I think sometimes in those, often that sort of phrasing and thought process helps parents become as comfortable as they can be with those sort of end-of-life decisions for kids. Yeah.
Well, thank you.
Yeah.
Thanks for coming. Thanks for doing the number 2 podcast.
Sorry for the tangents.
Hopefully there will be another 200.
Yeah. Yeah.
So, thanks for being here.
Yeah.
And thanks everybody for joining Tsuzen Luckey podcast number 2. Brought to you by Sue. Nick kept going. Sue. Sue. Tsuzen Luckey. Call me Sue. And thanks Toni Peters, Dr. Toni Peters, for being here.
Glad to be here. Thanks, Scott.